Hello, everyone. Thank you for joining this Neuroanesthesia round. I'm Eduardo Mendoza, and today we're going to talk about trigeminal neuralgia in neuroanesthesia. The learning objectives of the talk will be going through the definition, classification, pathology of the trigeminal neuralgia, talking a little bit about the management, drug therapy, interventional procedure, and some of the anesthetic considerations. So commonly, trigeminal neuralgia has been around for a long time, having descriptions since Vertigo to Dandy. And interestingly, one of the aspects that were part of that conflict between Cushing and Dandy was actually how to approach the trigeminal nerve. Recent publication in the Lancet, New England Journal of Medicine and Nature, points out the importance that this pathology has to the medical community. Commonly, the trigeminal neuralgia is referred as tic de Leroux, or the father-born disease, and we'll define it as a disorder which mainly is unilateral, having shock-like pains, which are of routine onsets and limited to the divisions of the trigeminal nerve. Now, more recent definitions from the ICHD and the International Association of Study of Pain will have somewhat common definition pointing out clinical features of the trigeminal neuralgia. However, they will differ in the subclassification of the trigeminal neuralgia, as we'll see after a couple of slides. The impact that the trigeminal neuralgia has in patients is big, being associated with suicide, and the majority of patients having high scores in the pain catastrophizing scale. But in terms of epidemiology, we'll say it's more prevalent in women than in men. Common risk factors associated with multiple sclerosis and hypertension. There's some literature talking about environmental factors and genetic prevalence in the familial type. For the diagnosis, will be very important to focus on the clinical features and its response to the drug therapy. Mainly, the trigeminal neuralgia will begin in the V2, V3 divisions, and will have those paroxysms or clusters of pain. So going through those clinical features of the trigeminal neuralgia, as you can see in this slide, they're very wide and broad. However, we could point out that between those episodes of pain, there will be what could be complete remission of it between weeks and months. Other aspect to highlight is the sensory changes. So previously, sensory changes in trigeminal neuralgia was not part of the definition. However, recent research has found that trigeminal neuralgia actually has subclinical subsensory changes during a diagnosis. And its response to the drug therapy will be part of the diagnosis. So every patient that is considered having trigeminal neuralgia should go to a round of drug medications. This recent publication from the New England Journal of Medicine, the authors were able to actually map the trigger zones and distribution from a sample of 120 patients, and being able to localize the intraoral and extraoral territories that will trigger the pain on the patients, as you can see in this slide. Regarding in comparison and for differential diagnosis, trigeminal neuralgia will have spikes or clusters of pain, and between them will have recesses or discontinuous. However, the other pathologies will have continuous pain and will gradually fade that pain. In terms of, I'm sorry for this busy slide, but it talks about the differential diagnosis in trigeminal neuralgia, beginning from multiple sclerosis, getting to syndrome, and many others. However, it's worthwhile pointing out that, as we mentioned before, trigeminal neuralgia will have subclinical sensory changes, but any major changes in sensation, paresthesias will help to differentiate from other pathologies. In terms of classification, we'll refer to the classical type, which affects mainly the alpha beta fibers, the idiopathic type, and the secondary type, which appears in approximately 50% of the patients. Now, there's a subtype, which is the trigeminal neuralgia that has continuous concomitant pain. So the patient has that shock and paroxysms of pain, but on the background, it has continuous concomitant pain. This has mainly been attributed to the C fibers. Now, among the two definitions that we previously mentioned, there's some common things to say. The idiopathic trigeminal neuralgia will have no diagnostic testing that will confirm any lesion. The classical trigeminal neuralgia will have and should demonstrate vascular compression. The secondary trigeminal neuralgia should demonstrate an underlying neurological disease, and the idiopathic classical trigeminal neuralgia will be further subclassified in having purely just the paroxysms or the concomitant continuous pain. So this slide will help us to understand a little bit more about the physiopathology and the classification. So I will refer to the ignition theory. So I will chart here the Pons, and you can see in the middle is the trigeminal nerve in its portion minor and major, and how once it goes out of the Meckel cave, where is the ganglion, we'll have that peripheral myelin, which is given by the Schwann cells, and will be do a transition to the central myelin given by the oligodendrocytes. So this part will be, let's say, a label part, which could be affected by a vessel that's in close proximity, and because it pulsates, will, with time cause demyelination of the fiber, causing further hyperexcitation, generating ectopic impulses. And that is how the pain comes. Now, if that demyelination comes before the entry of the Pons, either in this transitional part or just at the entrance, we'll refer to the classical type. If the problem of demyelination goes after once it's in the Pons, we'll refer to the secondary type, which could affect either the nucleus or any other part. And here will be all of the neurological pathologies, among them multiple sclerosis. And recently, there's another theory which refers to a subtype of sodium channels, mainly the 1.7. And there's new therapy that are trying to target those sodium channels to see if that makes any difference in the outcome. In this T2 with MRI image, we can compare the trigeminal nerves either on the left side and the right side, And we can notice that there is no sinal change, and the girth is the same. However, in the left side, you can see in this other image how the vessel, which is the supracervical artery, is looping down into the nerve in close proximity. And this eventually will cause changes in the nerve and produce the trigeminal neuralgia. Now, generally, the artery will encase, the nerve. And this image is just a kind of a beauty at very in close proximity. And the challenge for the radiologists and for everyone is to actually see if there are changes, because it could have or be in close proximity, but that has to have a correlation with the clinical features and if there are change in the signal during the MRI. So in terms of diagnosis, a combination of 3 high-resolution sequences have proved to be reliable in detecting vascular contact and predicting the degree of root compression, which are the 3-dimensional T2 wave, the 3D time of flight in MRI angiography. But in terms of treatment, there are a lot of things to talk about. And this is a chart of how the treatment of trigeminal neuralgia looks like. The first line treatment will be carbamazepine. We'll talk about that in just a second. There's the alternative treatment like motragine, baclofen, gabapentin. Local anesthetics, mainly lidocaine, will be useful for treatment of chronic patients with trigeminal neuralgia and also for acute flares up. Drugs under development, we'll talk about vigoftrigine. Some of the pre-surgical procedures, mainly botulinum toxin and inhaled CO2. Drugs in secondary trigeminal neuralgia, there are very weak evidence, but some studies proving that misoprostol helps in secondary trigeminal neuralgia. And drugs in trigeminal neuralgia with concomitant pain, in which we actually don't have much studies. So the drug therapy of the most recent guidelines given by European Academy of Neurology will stand that carbamazepine and also carbazepine will be the first line therapy and should be instituted in every patient from the beginning. And as we said before, that will make part of the diagnosis of trigeminal neuralgia. If that fails, or we could combine with other medications, and then we have lidocaine, gabapentinoids, probably botulinum toxin A and baclofen. So what's the evidence? Well, the evidence is not good, unfortunately, maybe only for carbazepine. Now, carbazepine, there are quite a few randomized controlled trials. The number needed to treat will be 1.9. However, the number needed to harm is 3.7. So the problem with carbamazepine is it gives a lot of side effects usage. Because of that, carbazepine has been advertised as being more tolerable for patients. However, the evidence is weak, as well for the rest of the drugs that you have available. This chart points out some of the randomized controlled trials available. And as you can see, carbamazepine is the only one that has strong strength and even moderate quality of evidence. So vigoftrigine is a newly drug which will target the sodium channel blockers, which is mainly NaV 1.7, which is a subtype. And interesting about this is that these receptors are not in the brain. So we're expecting to have less side effects. The phase 1 and 2 trials were positive. unfortunately, the phase 2 trial did not achieve its first endpoint, but it did achieve the secondary and third endpoint. And we're now looking out for the phase 3 results to see if the vixotrogene actually changes the outcome. The botulinum toxin type A is an exotoxin released by gram-positive bacterium and will block the TRPV1 receptor in C fibers. The use of botulinum toxin type A has been around for some time. However, the evidence is very weak. Now, it is on clinical trial is ongoing, and as well, we're looking to see those results if the outcomes will change at some point. And one last new exciting therapy is the intranasal non-inhaled carbon dioxide. There's some evidence that the CO2 has an anti-nociceptive effect, and that could potentially help patients in terms of pain. And as well, there is an ongoing phase 2 placebo-controlled trial having its primary outcome pain relief assessed by VAS, and we'll see the results shortly. So not only drugs are important, also supportive care that will help patients to get ahead of this horrible disease. So in terms of procedures, we'll have microvascular decompression, percutaneous procedures, and stereotactic radiosurgery. They differentiate among them that the percutaneous procedures and stereotactic surgery will aim to destroy either the trigeminal nerve or the ganglion, whether the microvascular decompression will like to preserve the function of the same. So going a little bit more detail on the microvascular decompression, we'll see that it's a major neurological procedure that mainly is to preserve the function of the trigeminal nerve. However, it has to be done through a craniotomy, mainly a rectal side-mount craniotomy. So this slide will help us a little bit understand how the microvascular decompression is done. You can see trigeminal nerve, usually the superior cerebral artery is going to be the vessel that is going to be closed and going to cause all the effects. And the aim is to put something in between. It could be sponge or something else to actually keep the function of the trigeminal nerve and prevent that demyelination that we talk in the AC pathology. The outcomes are good. We're going to go with 62 to 89% of the patients are pain-free at follow-up at 3 to 11 years. And complications, where there are quite few, probably hearing loss will be the most prevalent, facial hypoesthesia, and the risk of having a craniotomy. Now, what happens with the anesthetic considerations? So the anesthetic considerations will begin in pre-op to actually kind of have an idea and map, how the patient has that pain, what points of the face triggers pains the patient, so we can prevent touching them before putting the patient to sleep. Routine monitoring, and the goals from the anesthesia will be to provide brain relaxation, to keep a CPP, and prevent cerebral ischemia from the retraction. We'll have to remember that it's a very tight space, and the neurosurgeon will need to retract a lot to actually expose the trigeminal nerve. My recommendation today will be to do a total intravenous anesthetic. We can discuss that in another occasion. Will be very important to focus on ergonomics, because there will be some surgeons that would like to put the bench chair or the supine with a wedge, and that will limit the access to the tracheal tube and not actually facing the patient. So that is important to have that consideration. Will be recommended to use either hypertonic mantle. As we said, it's very narrow space, and to help the surgeon to prevent retracting too much, giving hypertonic mantle will be helpful. Use moderate hyperventilation, keep euvolemia, and there could be some potential bleeding because sinus, which is very close, and a lot of concern about the manipulation of the trigeminal nerve, which could have hypertension and a reflex bradycardia. So commonly, the first descriptions from the trigeminal neurology approach will be this position of the patient, which will be kind of a lateral with a bench chair position. Now, the importance of that retraction is that we'll have important structures nearby, being the superior cerebral artery, the interior inferior cerebral artery, and a little bit more ahead, the rest of the recurrent nerves. So because of that, it could have the recommendation to do evoke potentials and the auditory brain response. And if we do that, this is what we are expecting to see on our screen. All the trajectory, the pathway of the auditory system going from the organ corti to the auditory reflex. Good. In terms of percutaneous treatments, there are quite a few, going through thermal, chemical, and mechanical techniques that their aim will be to actually produce lesion and damage either the nerve or the ganglion. In terms of thermal, we'll have the percutaneous radiofrequency thermocoagulation, which will use a heated electron that cause thermal lesion into the nerve. It could be the chemical, which is one of the ones that we do in our institution, the percutaneous glycerol rheosotomy. And we'll see that a little bit more in detail. Mainly, the technique involves injecting glycerol into the ganglion and making damage. And there's another type, which is the mechanical approach, which will kind of insert a balloon and will look to compress the trigeminal nerve within the mecal cave. So the outcomes is important to review it to actually see, is it worthwhile or not doing those interventions. And for the balloon compression, in terms of pain-free, after 4 to 11 years follow-up will be around 55 to 80%, with the thermocoagulation around 30 to 80%. The glycerol rheosotomy, unfortunately, doesn't have that good performance in the long term. And through all those percutaneous treatments, most common complications will be facial hypoesthesia and anesthesia dolorosa. So in terms of the glycerol rheosotomy, as we said, it will involve insertion cannula. And this where it is important, this anatomic structure, the foramen ovale, is the one which this surgeon is going to aim to actually get into there and get the acuma in and get the glycerol into the ganglion. It is less invasive, however, less effective. As we said, we looked at that before, and the complications will somewhat will be less. In this table, points out all the studies I have done with the glycerolrhizotomy, and what is true is that pain wears off immediately. However, there are some descriptions that it could be an acute flare-up during the injection of the glycerol or shortly after. And that's why we use lidocaine infusion, but we'll talk about that in a second. So usually the patient will have this position. The patient will kind of switch among the position that the surgeon needs. And also the surgeon will want that the patient keeps a sitting position for at least 2 hours after the procedure to prevent the glycerol to go to the posterior fossa. So as you can see here, usually is used the common routinary ASA monitoring, and in this case, intratracheal intubation. In our institution, is done under conscious sedation, but either way. Now, because of that approach, and I wanted to point out in this image, in terms of the airway management, we can use either an LMA or a high flow nasal cannula, but be aware that the surgeon will need some space to manage that cannula. Once the cannula is in, through the foramen valley, we'll aim to get to the ganglion. And you can see in this image a little bit, maybe more clear, how the cannula goes through the foramen valley into the trigeminal cistern. So the anesthetic considerations for the glycerolrhizotomy, as we said, could be performed under conscious sedation or a short general anesthetic. Will be important to premedicate the patient for a vasovagal response. Either give it right from the start or have it ready. In terms of airway management, if the decision is to do general anesthetic, then either intubation, laryngeal mask, very high, or you can consider, I'm sorry, this is wrong, but consider a high flow nasal cannula under the conscious sedation. The lidocaine infusion, it is commonly used. We have in our institution is the LHSC protocol, which usually is used in the glycerolrhizotomy. It consists of bolus of 1.5 milligram kilogram and infusion of 1 to 3 milligram kilogram hour. Now, the question goes, well, what's the evidence of using lidocaine? In the glycerolrhizotomy or in trigeminal neuralgia. Now, unfortunately, the evidence is not big in this specific topic. We know that lidocaine, functions well in a lot of other topics, but this particular study was a randomized controlled trial in patients with trigeminal neuralgia, and they were able to lower the VAS score with the lidocaine infusion. So it will be useful during the procedure, but further research is warranted. This image of how the balloon compression works is pretty much the same, and it will kind of put that balloon into aim to get it into the medial cave and compress the nerve. Some of the anesthetic considerations for the balloon compression is that it's advised to have actually a pacemaker or a cardioversion device into the patient because there, a difference with the glycerolrhizotomy, the balloon compression will actually compress, right, the nerve, and the effect and the depressor response from that will be higher. So for that, there is some recommendation of using fluids and short-acting opioids. Usually for development compression, a short general anesthetic will be advised. And lastly, the stereotactic radiosurgery, mainly gamma knife, is the only invasive but destructive, the non-invasive but destructive technique. Patient will have pain relief 1 month after start, and the complications are generally less severe. And it's advised to use the stereotactic surgery in patients who cannot be who cannot hold a general anesthetic or a major procedure. Good. The follow-up again with the stereotactic surgery will have percentage of 30 to 63% of pain-free, and as we said, it's a good treatment for patients with more comorbidities. Complications will be facial numbness and paresthesias. Anesthetic consideration for stereotactic surgery, and I put this image because it brings to our head pretty much the same we have to with DBS or any other procedure that has a stereotactic frame. Sorry, so mainly the airway management in case we have to manage it, consolidation, and enhancing monitoring. So research is needed in many fields. We don't have at all randomized controlled trials comparing microvascular decompression with all the neuralgia treatments to see which one is better. Lidocaine infusion in glyceryl rhizotomy, as we said, lidocaine, it is useful. However, we don't have any big studies that advise its usefulness. And which technique is best or each procedure. Well, there's very scholarly literature, how to perform what's the best option for each of these procedures. And again, the comparison between neuralgia treatments, no studies available. So this is a summary of the outcomes of single intervention trials. We went through that, and I really appreciate your attention, and I'm happy for all the questions and discussion. Thank you.